very happy if you would like to present your concept of subspecialty neurosurgery.
Yes.
It's something very, very interesting.
Yes. Do you want me to do it right now?
Yes.
Yes.
Because it's a good moment for discussion during the lunch.
For lunch, okay, let me do that right now. So, as Professor Atka said, I'd like to share with you my view of where we should be, where we should be heading in the future of neurosurgery as we move to the future, and I want to share it. First of all, this is the baby boy thing. He's Superman, okay? Neurosurgery is very difficult. Neurosurgery is a difficult specialty. It is difficult for all of us. It tests your abilities, your mental strength. It requires us to really seek deep down inside ourselves and decide what kind of life we want to live ourselves and what kind of life we want to give to our patients. I think we have to rethink. We have to re-gauge the specialty in ourselves and our practice. Neurosurgeons around the world are struggling in a big way. They don't speak about it. They don't talk about it. But in private, I talk to many of them. They go home at night after they did the surgery and the patient had a bad problem, and deep in their heart they're struggling. Okay. It's a very common phenomenon in this specialty. So it's taken me some years to think, why is it so? Why is it so? Okay. And what can we do, not just to improve the neurosurgeon in their career and to be happy, but to really do the best for our patients? What changes can we enact that can do that? So I want to share with you my concept on this, and I shared this with the students yesterday. 100 years ago, at the Johns Hopkins Hospital in the United States, Harvey Cushing confronted the same question. But Harvey Cushing saw that there was devastating mortality going on in what's called cranial surgery. The concept of neurosurgery did not really exist. Essentially, the majority of the patients were dying after any time you opened somebody's head. He had some interest in the head and the brain, and one day he was looking at the board, and he and his colleagues who were surgeons at one of the top surgical institutions in the world at the time, that everybody, okay, your name would be you're doing liver surgery or thoracic surgery or brain surgery, and you picked one of those, whatever. He just felt that something is wrong. He confronted the question about mortality, what the question I'm posing to you about morbidity today. 100 years ago, he had the same question about why every other patient is dying. Can I do something different? So he felt this field is too high risk for it to be part of surgery. He said, I'm going to separate neurosurgery, make it a separate specialty. That made a lot of people upset at the time. And same problem I'm facing right now with what I'm proposing. But that's a 100-year interval. This is a problem, and I want to really delineate it very well without any vagueness about it. That happened 100 years ago. Let me tell you what happens today. Every board in the world, essentially, says this. Every board-certified neurosurgeon is an expert in every aspect of neurosurgery. Boom, stamp, you get the stamp. This is my statement. I stand by. There is no neurosurgeon in the world who's an expert in every aspect of neurosurgery. This is not a big, slight difference, let's have coffee. This is categorical difference in how we look at the world of neurosurgery. Okay? I'm certified, board certified to do brain surgery, aneurysm surgery, spine surgery, pediatric neurosurgery, everything. I choose not to do all those things, but I'm certified to do it, just like every other neurosurgeon. I make a categorical statement. Show me a neurosurgeon from any best neurosurgeon in the world who has this ability. You tell me every neurosurgeon is like this? Show me one. Show me one neurosurgeon in the world who is this. If you cannot give me that name, how can you tell me that every neurosurgeon is like, if you can't give me one name, you tell me every neurosurgeon is like this? Who's kidding who here? We're kidding our patients. We're kidding our families and the people we take care of in our population. We are essentially hurting ourselves and our patients, because this is, when I made this statement at major global meetings, I got a lot of people very upset with me. They are very upset with me. Many of these people, my friends, we don't even talk anymore because I said this. Okay? Some of these people I'm talking about actually believe this about themselves. That's even more dangerous. Let alone, we don't find this person, but you have people who actually believe this. That is the most dangerous thing there is, because then they really are hurting patients. So this created a big issue, between the Dengue Society and the World Federation, and I'm disappointed to see that the EANS is also siding with this. I think we're smarter than that. We're smarter than that. And just to be politically involved doesn't mean you have to side with this argument. We are better than that. We are better than that, okay? So, I showed the example, 2 cities, and one in Europe, one in the United States, each with about 1 million population. In this city, they have 8 neurosurgeons, each doing everything, each competing with each other. Same thing here in Spain. 1.2 million people, 14 neurosurgeons, practicing essentially separately, all doing everything, competition and all kinds of problems, okay? So what I have redefined the end outcome of neurosurgical training and neurosurgical practice to be one simple thing: patient outcome. Let's make patient outcome is the threshold. And let's make everything around this threshold. See, we have never defined it. By not defining it, it's very easy to say everybody's an expert. Well, let's define it. Tell me what is the definition of training, what's the definition of practice. Let's make patient outcome the definition. Once we do that, then we have to hold ourselves to a higher standard. How do you measure that? Well, over the last 5 years, we have looked at data in the United States of every subspecialty in neurosurgery. A simple issue has emerged. Neurosurgeon, high volume in a specific disease process, whether it's an aneurysm, a lumbar disc, or epilepsy surgery, operating in a high volume institution for that diagnosis. So let's say epilepsy neurosurgeon who has high volume, he's operating in a hospital that has a high volume epilepsy surgery. That combination has the best outcome, because the hospital systems then have the right technology, the teams, the neurologists, everything who can work in epilepsy. He or she is doing this all the time. They're technically very good at doing it. When you combine those two, you produce the best outcomes. Just an example, in the state of New York, when we look at this data, for unruptured cerebral aneurysms, when you look at low-volume surgeons at low-volume institutions compared to high-volume surgeons and high-volume institutions for unruptured aneurysms, the mortality was double. You double the mortality of the patient the minute you went from here to there. Okay? This is recent data. I mean, so these are the facts. And that is holding true for pediatric neurosurgery, spine, tumors, skull base, vascular. So what I have said in neurosurgery specialty practice, we have proof now, improves patient outcome. But what else does it do? Well, if every neurosurgeon is working in their area of expertise, they become an expert and an educator, okay? They develop research, whether they're an academic or private institution. That arm improves outcome, leave alone this direct data, okay? And then, if every neurosurgeon, if they are heads of that specialty in their own hospital, they're controlling the process, the protocols, the ICU, the collaboratives with other specialties. That will improve outcome. That will enlarge enrolling trials. And what I said, what is the future, which we should really be very aware of, that's already part of the Obama healthcare in the United States, but this is coming all over the world, that reimbursement payment to neurosurgeons would be linked to outcome. So let's be smart, okay? We should organize ourselves before governments tell us how to do it. That would be a lot worse. This is what some of these leaders that are upset with me don't understand. That if we don't take hold of this, this would be forced by governments. And when that happens, it's going to be a lot worse. So it's smarter to do it ourselves than to have governments intrude. And part of the concept is, people say, well, you have to take call, you deal with all kinds of problems. How can you, neurosurgery, small specialty? Well, there are two lives in neurosurgery. There's acute neurosurgery where you have to know how to deal with emergencies. Intracerebral hemorrhage, shunt malfunction, spinal cord compression, well, everybody should know that. Those are the basics. So you should learn that. Then you should concentrate in an area in which it's going to make you a high-volume surgeon in a high-volume institution. That is your elective practice. Okay? So in the United States, we have training that's 7 years. Okay? 7 years, we train everybody in everything. At the end of the 7 years, we graduate people who are mediocre in everything. Nobody's an expert at the end of the 7 years. Well, how do you change the 7 years? What I'm saying, proposing, first 4 years should be acute neurosurgery training. How to deal with emergencies. Everybody should learn how to deal with the patient at 3 in the morning. Then, 1 year of research in the area the person is interested in. That's what they're going to do the rest of their life. Let them do research, learn about it. Then 2 years of subspecialty training. Where? Well, if your hospital does only 5 epilepsy surgeries and your chief resident wants to become an epilepsy surgeon, in 2 years they're going to do 10 cases. Well, that's not going to train somebody. You have to have an exchange program between big programs. So the example I gave yesterday, if I have a resident who wants to do spine, my program is very big cranial. I send it to Ed Benzel at Cleveland Clinic. He has a chief resident who wants to do skull base and vascular. He sends it to me. And they spend the 2 years with us. We exchange the residents. Then they graduate and become graduates from their own parent programs. In continents like Europe, this perhaps exchange program needs to be continent-wide. The countries are not big enough to provide that kind of high-volume centers in every country or every specialty. So in a continent like Europe, in South America, and even in Asia, we're proposing continent-wide exchange programs for these last 2 years. And then this person finishes. Now what kind of practice are they going to do? Well, you can't put them back in the current practice system. You have to put them in a group of 8 or 9 neurosurgeons where they now become the epilepsy surgeon. And perhaps there is a senior surgeon who does epilepsy that mentors them to then increase their expertise. If you take this person and put them in our typical system, you go work, you do everything, well, they're not going to develop the true skills. So it's not just change in residency, but it has to be change in practice. It has to go together, all right? And for practice, we have defined 12, so it's not just one subspecialty. You see, functional and pain, neurotrauma, and then you could combine tumor and skull base, or tumor and functional. There are certain areas that are complementary, and so that you don't, so it's these 12 categories. So what happens if you're currently, there's 8 or 9 neurosurgeons working in one region, they come together and meet and decide who's interested in what, and say, you know what, we want to work as a team. I will send you my tumors, you send me your spine cases. Okay. What's even better, combine financially. Say, we're one group. Okay? Let's put all the money in one pot. Whatever comes in, put the money in one, so there's no competition from a financial standpoint. Put the money in one pot, then have a system of distributing the money on the amount of work done. A point-based system, objective point-based system. That way there's no financial competition. That way you get to do what you like to do. Every day you get to do what you like to do, and you get paid for it. So that is that's what I do in my own department. This is how my department is structured. And it took away competition. People are helping each other. They're giving cases to each other. They're not competing with each other. Because everybody gets to do what they like to do. They go at all the time. They're happy. They're going to specialized conferences because that's the area they're interested in. They're doing research in that area. We need this kind of future. So what happens if you combine all those neurosurgeons in Cape Girardeau, and you combine all the cases in Spain, all the patients in New York, they have this situation. They are combined together. They have improvement in education. They have stronger bargaining power with the hospital. Hospital can't tell you, we're not going to buy you a microscope. Well, we're one group. We need a microscope for all the guys to do enders and clipping. We need image guidance for our tumor guy. If you guys don't get it for us, it's a big problem because we are the neurosurgeons in this town. You will have to be with us, right? You're a lot stronger than you alone going to talking to the hospital administrator. All this leads to better patient outcome, okay? So the neurosurgeon's life is that he or she is working in a group, is a clinical expert in acute neurosurgery in their area of subspecialty, and they can be involved in research and education, okay? If you go on our website, we have the references for all the major areas of neurosurgery, how the outcome is directly related to the numbers of the cases of the surgeon and the hospital. Direct relationship. This is not a vague issue. These are factual issues that we have gathered over time. So I think this will be a good discussion item during lunch. We can have a discussion about it together as a group. What is needed, really, if you, the professors, is reaching to the next level? What can you do for this next generation? And I think what I appeal to the leadership of neurosurgery, put the ego aside, societies aside, warring between, well, I'm World Federation, I'm ENS, this is the stand we're going to take. Well, I mean, that's very childish. I think we need to be able to work together to rethink the specialty in a different way. And what we are willing to do as part of this, because you're going to be in a subspecialty, there will be an exam, just like an oral exam you have after the end of your neurosurgical training. And that will have a certification. We will make that certification global. The exam will be in the United States, where the dengue headquarters are. But with that global certification, you become a fraternity with your colleagues around the world because you have all the same standard. And now that allows much more collaboration at the global stage because your area are your friends, this is what you do, you have friends all over the world, you do what you do, you always meet with them. So I think that would be the way that I'm proposing. I am very surprised about the very strong dislike for this by major authorities around the world. I am very surprised by it. But knowing some of the personalities, it actually goes with the personalities. But neurosurgery is not, this is not, we're not in a dictatorship, okay? I mean, you get to decide, all right? I mean, this is not some president of some society should decide for you how you should live your life or how the next generation should practice. No, this should be a meritocracy. We need to be able to openly discuss this and do the right thing. This is what I believe. So I think it's high time for us to rethink this because we cannot continue what we're doing. That's the bottom line. We cannot continue what we're doing. There's so many patients being hurt every day all over the world because of this current system. Is it the fault of the neurosurgeon? No, it's part of the system that we have created to put them in that position. And then they live miserable lives. They're having complications all the time, and they're in bad mood all the time. I mean, why? I mean, why do we need this? All right. So I want you to think about it. I think the reason I'm traveling around the world personally is a lot for this message because when a lot of the hierarchy of a lot of the big societies just don't want to hear these words, I feel it's best for me to meet the neurosurgeons myself around the world, because they get to decide. There is no, this is not a monarchy. I mean, they don't get to a few people because their personal political interests choose to keep the specialty in a direction towards a car accident. So I think, I do hope that you will think about this in a very objective way, and I think the next generation deserves a direction that will really grow our beloved specialty. It is the next biggest frontier in medicine. We discussed a lot about that. Neuroscience research is what we discussed much yesterday. It has so much to be done, and we need this next generation to be contributing to it. They can't do it if they're doing everything out there, and they have to do it if they are in areas of interest. So thank you for your time. Really grateful.